Hello, good morning, everyone. How are you? My name is Deontay Marquis, and I am a family nurse practitioner. And today I will be with you for the next hour or so, and we will be talking about diabetes care and management, specifically for the certified nursing assistant or unlicensed assistive personnel. Now, if you're a registered nurse, be aware that I am presenting on behalf of myelftraining.com, and there is a separate presentation specifically for you for registered nurses, um, with similar content, a little bit more in depth, about diabetes and care. So please reference that video. This one is specifically for certified nursing assistants and unlicensed assistive personnel. So we're going to jump right in. Our course objectives for today, we have four, but I packed a lot of content into this presentation. So a lot of good information. So our first objective that we're going to be walking away from this PowerPoint presentation today is I want you to be able to understand the different types of diabetes. I'm a big believer in order for us to change the way that we treat our patients, or the disease that our patients have, we really need to understand the disease that we're treating. So understanding that there are different types of diabetes and understanding how they all individually affect the body of our patient is going to be the first big course objective for us today. The second will be identifying signs and symptoms of two of the most common symptoms of diabetes, hypoglycemia and hyperglycemia. And we will touch on some aspects of emergency treatment plans that you will be involved in helping the nurse to make sure that we prevent those emergency situations from becoming worse. Our third course objective is going to be identifying elements of a proper nutrition plan for the patient with diabetes. So diabetes, I'm sure you have the understanding that the patient's body has trouble with um, controlling the amount of sugar in the blood, which is why we're always checking their blood sugar. So the body isn't just making that sugar, though; it's coming from the foods and the nutrition that the patient is eating. So we need to make sure that we're putting in the best foods for the patient, so that the insulin is maximizing its effects and keeping the sugar at the lowest level possible. And we will understand why that's so important later on in this presentation as well. Now, our fourth course objective is understanding the importance of and being able to verbalize methods to prevent and treat diabetic foot ulcers. Diabetic foot ulcers are a large part of the care that CNAs and unlicensed assistive personnel like yourselves will be looking after and helping the nurse to manage, as patients with diabetes tend to have very high vulnerability to foot ulcers because of the decreased sensitivity to the extremities, specifically the feet and hands, and also their inability to heal wounds properly. And that's just a result of the disease, diabetes as a whole. So those are our four main objectives. And now, just in case, just to narrow in even more, because I know everyone wants to know what's my job in this, what's my role. So focusing your care, there are four pieces of the pie. I'll put a picture of a pie there. Just it's my sense of humor. You know, diabetes aren't supposed to be having pie, so I'll put pie. Uh, a little dark humor. Anyway, so the four pieces of the pie. The first big piece of the pie of your care, of your part of the care, and helping manage diabetes, helping manage the patient, is diet and exercise. So a lot of the times in my experience, the registered nurse is tending to the patient or the doctor or medications, or has several patients. So a lot of the time we trust unlicensed assistive personnel with helping the patient eat, assisting them with finishing a meal, or even preparing the meal for them or retrieving the meal for them. So knowing which foods are the best for the patient, helping them make smarter decisions, and also encouraging them to go one more when they're exercising to increase their strength and conditioning, and just to make sure that they're getting their recommended 30 minutes of activity a day. So that's a big piece of the pie, number one. Number two is education. I mentioned in number one, talking about diet. It's going to be our responsibility to educate our patients and make sure that they too are recognizing what foods are the best choices for them, and how much of those foods that aren't the best choice are they allowed to eat without seeing serious interactions with the foods they eat causing their blood pressure to spike. So that's number two, another big part of the pie. Number three, recognizing hypo and hyperglycemia warning signs. So uh, that's another large part of your care and responsibility, is being those extended eyes and ears for the nurse, recognizing signs and symptoms that the blood sugar is dropping low, knowing your patient, knowing when something's wrong, and knowing what to look for in these diabetic patients, this very vulnerable population. Wound care and prevention. So wound care and prevention, again, as we touched in the objectives, to me is a very important part of the pie, because again, patients who have diabetes, they tend to have trouble with wound healing. So it's very important that we're taking the steps necessary to prevent wounds from occurring, specifically diabetic foot ulcers, and also that we are doing and steering the patient in the right direction to make sure we're doing everything we can to help revive the foot, increase blood flow, and prevent any further breakdown when there is the presence of a wound to the foot, a foot ulcer. So all of that, we're still focusing in on our care because I want you to know what the rest of your medical team will be expecting from you and how we can definitely meet and exceed those expectations. So the goal of diabetes management is to keep levels of blood glucose, blood pressure, and cholesterol levels as close to the normal range as safely possible. And why is this important? Because research has been showing us that when we keep the blood glucose levels as close to normal as possible, it can help reduce risk of the patient developing these major complications of diabetes, which are so frequently associated with patients who have diabetes, that it makes management of a patient in a long-term care facility for any extended amount of time difficult for the healthcare workers there, because there are so many different factors that come into play when we're caring for patients who have diabetes type 2 and who have had it for any significant amount of time. Because basically we have to reteach them things about the way they live while they are adjusting to living in a long-term care facility and experiencing the complications which have occurred down the road from them not properly managing their diabetes earlier on in the road. So this is the main goal of diabetes management, but focusing on your care is the previous slide that we talked about here. Okay, so first objective, I said we were going to talk about the different types of diabetes. So the first type of diabetes is called diabetes type 1. Now, diabetes type 1 isn't the type of diabetes that we all have commonly come to know. Diabetes type 1 is actually the result of an autoimmune disease, which happens generally when the body is fighting an infection. So the immune system is helping to fight against an infection, and it turns against the body because it's just trying to annihilate this infection, that it just starts attacking the body. And what happens when this occurs is the insulin producing cells in the pancreas are then killed. And then that is why the patient must start taking insulin. So here I included this diagram. This is healthy pancreas. and it's producing insulin. These green drops here, this is glucose. They had a piece of the pie. And then the insulin grabs hold of the glucose and moves it into the cell and keeps it from moving freely about in the blood. Now, in a diabetic patient, you see here, specifically type 1 diabetes, the immune system cells, they have destroyed a part of the pancreas. And because they have destroyed this part of the pancreas can't effectively create insulin because it uses its whole self to create insulin. But the immune system has destroyed a piece of it. So it's damaged. So the end product is now damaged. So the pancreas can't make insulin. So when the patient eats a piece of the pie, now they have all this glucose floating around in the blood, which is why they have to take insulin, check their blood sugar, watch their diet, and we just see this snowballing effect because of this continued increased amount of glucose in the blood. Okay, so we talked about type 1 diabetes. Type 1 diabetes is the result of an autoimmune disease that affected the pancreas, and it can no longer make insulin. Now, diabetes type 2, this is the most common form that you and I have more than likely met someone with, have a family member who has it, a grandmother, grandfather, an aunt, uncle. This is it. This is the diabetes you will more than likely be caring for when you step into your place of your healthcare facility to work. So people can develop type 2 diabetes at any age, even during childhood. But it is much more common in older adults, as we have seen in the general population. Commonly, people with diabetes type 2 are older, they're obese, they have some type of familial history of diabetes, they're generally physically inactive, and they may have had gestational diabetes. And I'll touch on what gestational diabetes is in a moment. But I just want you to note these characteristics of diabetes type 2. So these patients are generally physically inactive, obese, it's in their genes, and they're a bit older. So we're working against all of these odds. And on top of that, now they have this disease which is going to be with them. So let's talk about gestational diabetes, because that was also a cause of type 2 diabetes. So gestational diabetes occurs late in pregnancy for some women. It usually goes away after the woman has the baby because the baby is introducing a lot of new hormones, causing the woman to eat more, moving less. You know, the baby brings on a lot of stress until birth. But however, women who have had gestational diabetes are at an increased risk for developing type 2 diabetes within 5 to 10 years. Um, Now, the exact reason for that, I'm not 100% sure of, but um, this is something to be mindful as well when we're caring for the patient and collecting a history and talking with them about their history with their diabetes. We want to know, did they get diabetes type 2 after pregnancy? Or did they have gestational diabetes during pregnancy? Because then we can still take some information about the type of lifestyle they led, and then therefore we can set our goals specifically and individualized for that patient. Based on the type of lifestyle that they led, we can set realistic expectations of how we expect to help them better manage diabetes. Let me move myself out of the way here. Okay. So diabetes effects on the body. So why is it so important that we help these patients better manage diabetes? I mean, you know, you may be saying to yourself, they're taking insulin, we're checking their blood sugar. What is so important that we now have to make it very difficult for them, some of them, and to go as far as changing their diet so drastically if they're taking the insulin when the blood sugar is high? What's the reason? Well, it's because over time, diabetes causes very severe microvascular breakdown. Now, if you recall in this previous slide here, we talked about the difference between a healthy pancreas and an unhealthy pancreas, and how the unhealthy pancreas of the patient with diabetes, there's more glucose in the blood. So if there's more glucose in the blood, which there shouldn't be, it can cause increased peripheral vascular disease, which is basically you see this buildup. So just imagine some old pipes. It's getting rusty and there's buildup on the side. So the water isn't flowing through as it should be. So this is the microvascular breakdown. And this can lead to problems in areas of the body where we have increased microvasculature. For instance, in the eyes, we have very tiny blood vessels. So if enough sugar builds up here, then we can't get the proper amount of blood flow to the eyes. So we have patients with diabetes develop retinopathy, which is a myriad of symptoms that affects their vision. They have very difficult trouble seeing, wear glasses, maybe having eye pain, things like that. Also, patients with diabetes, microvascular breakdown can also cause increased hypertension or blood pressure. It can lead to even more severe diseases such as a stroke or a heart attack or chronic kidney disease where the patient needs dialysis. So I included this uh, picture graph here to show how diabetes intertwines with high blood pressure, which then leads to even more severe symptoms such as stroke. So there's a picture of a brain here, or heart attack. Patients with diabetes and hypertension are 3 times more likely to have congestive heart failure, which can lead to a heart attack. Patients with diabetes are 2 to 4 more times likely to have peripheral vascular disease, which worsens their blood pressure. So these are difficult patients to manage. It goes further beyond checking their blood sugar and delivering the appropriate amount of insulin. This is why it's important for us to do our part, as we talked in the beginning of this presentation, and we talked about our part in helping the healthcare team to better manage diabetes, because the patient that we're taking care of in the LTAC is now older. They more than likely have not been managing their diabetes correctly. And even if they have, just the nature of the disease of diabetes, they can suffer from microvascular breakdown and all these other complications that we talked about here. So I include this slide because this is the specific challenges to care in patients with diabetes. They likely have hypertension from the peripheral vascular disease. They also likely have chronic kidney disease. So that means they're needing dialysis as well. And given dialysis while the patient has high blood pressure, that affects the blood pressure as well. And sometimes patients aren't allowed to eat. If you give the patient insulin while they're getting dialysis, then the dialysis will rinse the insulin out sometimes. It won't be as effective. And also cardiovascular disease. So just the breakdown of the microvasculature, like we talked about. And this would cause the serious issues with the brain, so a stroke, or the heart, so congestive heart failure or a heart attack. So this is why, again, it's important that we learn to better manage diabetes. So the first step in better managing diabetes is recognizing the warning signs and symptoms of hypoglycemia. So hypoglycemia is when the blood sugar is less than 70. So if you're helping the nurse and you take the blood sugar and it's less than 70, then that patient has hypoglycemia. Now, if you're not taking the blood sugar, or if you already took the blood sugar, or you just walked by and you note something's not right, these are the symptoms that you should look for. And this is the mnemonic that you can use to help you remember these symptoms. The mnemonic is tired, T-I-R-E-D. The first symptom in this mnemonic is tachycardia. So if you notice that the patient's heart rate is increased more than it normally is for that patient, and they're not doing any activity, they're resting, watching TV, or reading a book, that should cue you in that something might be going on. So you should continue down to the mnemonic tired with the I. I is for irritable. So if the patient seems not to be as pleasant as they usually are, um, or restless, that's the R in the mnemonic, or they are excessively hungry or sweating. D is diaphoresis. Diaphoresis is a fancy way of saying sweating. So tired, that's the mnemonic I want you to remember. Tachycardia, which is a fast heart rate, anything greater than 100. Irritability, they're restless, they're increasingly hungry, or they're sweating, diaphoresis. And these are some pictures as well. You see she's sweating, she's very hungry, she's irritable, sleepy, that's restless. So just the different symptoms that will present. They don't all have to be present together, but these should clue you in if your patient is a diabetic that maybe you should take their blood sugar to see what it is, or if they're starting to exhibit these symptoms, let the nurse know that you think the patient may be hypoglycemic. And also let the nurse know when you tell them the last time you took the patient's blood sugar, what it was, or the last time the patient ate, and what they ate and how much of it they ate. This is all important information for the nurse when you're giving them any kind of update that may be concerning that the patient is suffering from hypoglycemia. So here I just get a little bit more specific with the numerical values of the hypoglycemia. So mild symptoms, we use the TIRED acronym, and that's pretty much what you need to know. If it's less than 70, they're hypoglycemic. Now, if you check their blood sugar and it's 40, then you need to immediately run to the nurse, drop the glucometer, and say, we need to do something quick because the patient is at risk for falling into a coma or having a seizure. Moderate symptoms would be blood sugar less than 55, and we can expect symptoms such as blurred vision, confusion, or slurred speech. Got it? All right. So, I mean, what do we do? You walk into the patient's room and you notice that they are a bit tachycardic and not as nice as they usually are, and they are sweating for some reason, and the air condition is on. There's no reason to be sweating. And they're asking you for food, and they just ate. And you say, I think you may be hypoglycemic. What do you do? Or what can you expect the nurse to direct you to do, or how you can help? Well, the treatment protocol, this is across the board, for a patient who's hypoglycemic, you want to offer 15 to 20 grams of carbohydrate. This is going to rev up their system, keep them from falling lower. 4 ounces of juice or regular soda. If their favorite drink is Diet Coke, don't give them their favorite drink. Give them Coke. Give them the real thing. This is a common mistake sometimes I've seen in practice is you want the patient to drink whatever it is you give them. Some patients are picky, especially if they're going through a hypoglycemic episode and they are irritable. You want to give them something that you know they're going to drink, and they're going to drink it fast. So you give them their favorite drink, and of course their favorite drink is going to be something diet because they're a diabetic. So we want to make sure we give them regular soda, 4 ounces of juice, or 8 ounces of milk because you need to get that extra glucose, or glucose tablets. Now, depending on what type of glucose tablets they take, it will tell you how many. In my experience, it's either 2 or 3. So we give them some orange juice. The patient drinks it right away. We wait 15 minutes. We check the blood sugar again. The blood sugar says 78. So if the blood sugar says 78, what do? We offer them a meal. But if we recheck their blood sugar and it's less than 70, it says 65, so it went up from 60 to 65, then we repeat steps 1 and 2. So we give them another 15 to 20 grams of carbohydrates, and we recheck their blood sugar in another 15 minutes until the desired glucose level is 70, until that glucose level is achieved. Now, why is 70 the desired level? Because anything less than 70 is hypoglycemic. So step 4, if the blood glucose is within normal, so we recheck it and it's 70 milligrams per deciliter, but it's not mealtime yet. For whatever reason, it's not mealtime and it won't be for another 2 hours. Then we give them 7 grams of protein. Now the protein is going to should last and keep their blood sugar up, give the body something to break down, to keep the blood sugar from falling again, so they can make it to mealtime until they ingest some more food and have some more of their favorite diet soda. That is how we manage hypoglycemia. Now, hyperglycemia. Hyperglycemia occurs when blood sugar levels are greater than 180. Greater than 180 is hyperglycemia. There's no fancy mnemonic to help you remember the symptoms for hyperglycemia. I remember them, I call it the too much food effect. So the too much food effect, if you sit down on a Saturday and you enjoy a great big pizza to yourself and watch your favorite movie, after you eat that pizza, you might be very thirsty. You might have dry mouth from all the crust, all the bread. Your mouth is a little dry. So you're very thirsty. And then you're so thirsty, it's all gone. You're drinking and then you're urinating. It's a continuous vicious cycle. And it's because you ate so much, of course, you're very sleepy now. You're fatigued. So this is the too much food effect. Hyperglycemia has similar because you've eaten too much. Your blood sugar's too high now. So your body's trying to break it down and it needs some more water. Now, patients with diabetes, if their blood sugar goes above 250, it can cause them to go into something much worse than just hyperglycemia, which is diabetic ketoacidosis. It is more commonly known as DKA. Now, just because the blood sugar is greater than 250, that does not mean the patient is automatically suffering from diabetic ketoacidosis or DKA. There are another group of symptoms and different tests to see if the patient is actually in DKA. But the biggest telltale sign that the patient is suffering from DKA and their blood sugar is greater than 250 is if you lean in to talk to them and ask them how they feel, their breath will smell very fruity. I can't explain it. It's something you have to have experience for yourself, but it is an unmistakable smell paired with the patient being a diabetic and having a high blood sugar. You will know when you smell the DKA breath. It's just very fruity. So moving along. Also, the patient will have symptoms such as nausea, vomiting. They'll be complaining of abdominal pain and they'll still be complaining of increased thirst. Now, if your patient has a blood sugar greater than 250 and you smell this breath, you need to notify the nurse as soon as possible. Or if your patient's blood sugar is greater than 250, you still need to notify your nurse as soon as possible, but just not with as much urgency as if you think it may be DKA. But of course, we want to let them know as soon as possible because we don't want the blood sugar going any higher. We don't want the patient eating anything else and putting them at risk. So let's talk a little about eating. What should our patients be eating? How can we help them make better selections about the foods that they eat? Well, let's get this slideshow. Okay, so the best way to help your patient improve their eating habits and develop a better meal plan is to, when you're helping them prepare their meal or you're assessing their meal before they eat, you want to use what is called the 9-inch dinner plate. Now, the 9-inch dinner plate, it doesn't have to exactly be a 9-inch plate for you to do this. You just have to cut the plate in half and then cut one half of the plate into another half, as you see here. So first we cut the plate in half, and we have one half, two half, and then we cut half number two into half again. So we have 1/4, 2/4, and then 2/4 over here. So we have a whole plate. Now, after you do that in the 9-inch dinner plate method, it calls for you to fill half of the plate with non-starchy vegetables. So, what are non-starchy vegetables? I'll let you guys tell me. Non-starchy vegetables would be the greens, the floury vegetables. When I say floury, I'm thinking of broccoli. So salad, the leafy vegetables, not floury, I'm sorry. Leafy green vegetables, um, salad, green beans, broccoli, cauliflower, cabbage or carrots. So a lot of the times, if you see a patient's plate, they'll only have one portion of greens on the plate, and then the other half will be the meat, and then it'll be a starchy vegetable like mashed potatoes, or it'll be a side dish like beans. But the way that their plate is supposed to look, it's supposed to be 2 scoops, 2 sides of veggies, 1/4 with lean protein. Some examples of lean protein would be cheese, chicken, turkey beans, tofu, or eggs. Now, for example, in the morning, if your patient likes eggs for breakfast and you want to make them an omelet, let's say they like an omelet. If there's a cook or kitchen, you want to make sure that the patient is that before they make the omelet, that they're using the 9-inch dinner plate method and making sure that 1/4 of the plate is meat. No, I'm sorry. A 1/4 of the plate should be the meat and the eggs. It shouldn't be 1/4 of the plate meat and 1/4 of the plate eggs, because then that's too much lean protein, and then that's not enough non-starchy vegetables. So that's the kind of small changes that we need to make sure we're looking out for, and make sure the rest of the healthcare team are making note of and also looking out for, because that is the correct way and appropriate diet for diabetic patients. Now, so we have our omelet, we have 1/4 of the plate with eggs and meat, and we have another 1/4 of the plate with their grain or their starch. So this will be their toast, or their biscuit, or their hash browns. That will be next to the eggs and the meat. And now this other half of the plate that we talked about that needs to be all green leafy vegetables, um, we can have spinach. So just all spinach sprinkled here. And then when the kitchen goes to make the patient's meal, they take the ingredients that are on the plate and use all of them to make the omelet. So the meat, now they have the right amount of spinach, and it's not less spinach because there's more meat. It's the proper mixture and balance of all the correct food groups that a diabetic patient needs to have to make sure that we are sustaining their blood sugar at at a level that will support the insulin to best regulate any blood sugar that any sugar that enters the bloodstream. Now here's just a chart of some common fruits. So in my experience, the biggest difficulty for even myself, when I'm trying to watch my diet every day, is snacks. Choosing a healthy snack. We know we shouldn't be snacking, but it's something, if we're being realistic, we can't get around it. So we need to make sure we're making the healthiest decision for our snack so that it's not messing up the rest of our diet. It's not messing up the rest of our nutrition. And that same goes for diabetic patients, except I think it's even a little more difficult for them, especially when their three meals are very regulated and they want to have a snack in between them. They want to reward themselves sometimes for eating correctly. They have cravings just like you and I. Um, or maybe they are eating one of these foods. Now, would you say, given the amount, which is the suggested serving size, that someone would eat 1 cup of grapes? I think that's very reasonable. 1 whole banana, I think that's very reasonable amount. Someone might eat in one sitting. 1 medium wedge of watermelon, I think that's a very reasonable amount. Now, looking at these fruits, serving size, and amount of sugar, would you say these are good choices for a healthy snack? Or would you say that these are bad choices for a healthy snack? And if there's one fruit on this slide that you think in particular would not be a good choice for a healthy snack, then I want you to write that uh, snack down on a piece of paper. And next to it, put how many grams of sugar are in that snack. All right. I'll let you look at this and pick one or two. On the next slide, I'll let you know which one is the worst. Is the patient most likely to overeat? I know mangoes sticking out to a lot of people. Grapes are sticking out. I eat a lot of grapes if I have grapes, definitely more than 1 cup, and a banana probably. Okay, so let's go to the next slide so we can compare which snack is the best snack. None of them are the best snack. Look at that. Look at the difference here in these fruits versus these fruits. All of these fruits are double-digit sugar, but they seem healthy. Yes, they're healthier than the bag of chips, but the bag of chips is unhealthy. The fruits with sugar are healthy, but not for a diabetic. These are the fruits that the diabetics we should be offering and encouraging them to have. Instead of a banana smoothie, a strawberry smoothie, there's a lot of sugar in a banana, especially if it's a little bit older and it's been fermented. Avocados, they can have 1 whole avocado. Yes, the avocado has more fat, but these patients, we are managing their sugar. So the less sugar, the better. A guava, they can have an entire guava, which is only 5 grams of sugar, as opposed to 1 wedge of a watermelon, which is 17 grams of sugar. Papaya, cantaloupe, raspberries, they can have 3 cups of raspberries is 15 grams of sugar. Would you tell them to eat 3 cups of grapes? It's a lot of sugar. So I did that. I tricked you guys. I'm sorry. Just to show you the difference in eating healthy, no, in eating unhealthy, in eating healthy, and then eating healthy for a diabetic. There are 3 different levels. And unfortunately, at the bottom, the most strict has to be our diabetic population and watching what they eat. And that's why they need us. And that's why I'm trying to help you guys, give you this information so that we can help them and improve the way we manage our care for them. Now, continuing on with nutrition and diet. Oh, whoops. Let's see here. So Nutrition and diet, CNA's responsibility. So I keep talking about you guys' responsibility, what your role is, because I feel like without knowing what your role is, you kind of just go with the flow. But with going with the flow is good in some instances, but we have a specific role for everyone in the healthcare team. And with that role comes certain responsibilities. And we're all working towards the number one goal, which is to keep our patients safe, happy, and healthy. And in order to do that, everyone know their role and know the responsibilities that accompany that role. So, CNA's responsibility as far as nutrition and diet would be number one, being supportive and empathetic. Now, I mentioned on the last slide that the patient, they may be having difficulty. I showed you guys, they may be having difficulty with uh, cravings that they may be having for foods that they shouldn't be having. Maybe they are trying to buy into the care that we're providing them, the education. They're just realizing that 3 cups of grapes wasn't the healthiest snack, but they're still craving those grapes. And it can be problematic, especially for our elderly population who's living in an LTAC facility. They've already lost a lot of their independence, their family. They're not living where they used to. They're trying to adjust to a new place and new care being provided to them. So they're transitioning into a different life. They're transitioning into a healthier life. And we need to be supportive of them. We need to be empathetic towards what they're going through, but we need to help them realize that why they're on this diet. We need to talk to them about the long-term effects of diabetes, some which they may be experiencing already, and get them to see that, get them to understand that, these symptoms that you're experiencing, they're not going to improve. They're only going to get worse if we continue eating and doing the things that we were doing. We need to make these changes, and they start today. And we need to be supportive and empathetic towards them. So what to do if this happens to you? Well, you explain the importance of the food choices to help the patient understand why they're on the diet. Simple as that. We need to explain it to them. So if your patient's used to having 3 cups of grapes as a snack, and of course the normal person who uh, eats healthy and exercises, grapes are a very healthy snack. Um, it's not a high amount of carb or fat. It's got some sugar, but if I'm working out and exercising, I'm healthy, some sugar doesn't affect me as it does somebody with diabetes. So we need to help them understand that, we need to cut back on the amount of grapes until we completely cut the grapes out. And we're going to try raspberries, or we're going to try papaya, or we're going to try avocado. We need to try different options, help them find their new favorite snack. Um, Second, CNA's responsibility is keeping a clear record of all the food they consume and the corresponding glucose levels throughout the week. So this is important. I don't know if you guys recall, we talked about managing the patient with hypoglycemia and uh, reporting to the nurse about what the patient last ate and how much they ate and what their previous glucose level was. If we go into a room and notice that the patient is exhibiting symptoms that align with the tired mnemonic that we talked about. So having a clear record of this information can help you be a better CNA, tune you in a bit more to what your patient is doing as far as nutrition goes. And it'll help your nurse also provide faster, more effective care to your patient, and help the nutritionist guide their nutrition plan for the patient. So we're really dependent on you guys to get a lot of this information that's going to help direct care for the patient. Um, so I put here, it will help the team visualize, it makes a visual representation of the patient's eating habits and blood sugar pattern, and will help you and us recognize and prevent possibly dangerous health situations, such as hyperglycemia, DKA, or hypoglycemia, um, blood sugar extremely low. Because if we're following what the patient is eating closely and their glucose levels, then we're able to identify these things early on. And last, one of the most important CNA responsibilities is reporting to the nurse any abnormalities in food intake, such as skipping a meal or sudden changes in the appetite. Now, this I know it's not that big of a deal in healthcare. If a patient skips a meal, if I skip a meal, it's not that big of a deal. But in healthcare, this is a very big deal, and especially with our diabetic patients, because we need to have a continuous flow of the right amount and right foods going into their system to make sure that it's working together with the insulin that they're being given to sustain their blood sugar at an adequate level. We don't want it going too high. We don't want it going too low. So if they skip a meal, then it's going to drop low. So it's the nurse assistant's responsibility to inform the nurse, hey, the patient only took one bite and then fell asleep. Mr. Johnson said he wasn't hungry. He went to sleep. He skipped lunch. Well, when Mr. Johnson wakes up, his blood sugar is very likely to be extremely low. Or if the CNA takes the patient's tray out because he's sleeping and the food's sitting there, and the nurse comes to give him his insulin, and he doesn't tell her that he skipped a meal, then the nurse is going to give Mr. Johnson insulin for food that wasn't eaten. And what do you think is going to happen? His blood sugar is going to drop. So we need you guys to follow number 3. This is very important for me, is reporting to the nurse inadequate intake. So if they're not eating enough, if they're not eating at all, and if they're drinking a lot, or if they're exercising a lot for some reason, we need to let the nurse know. Maybe there was some type of dance activity and your patient really had a great day, really enjoyed themselves, a lot of activity, sweating, having fun. That's fine. That's what we want. But at the same time, the healthcare staff needs to be aware of this. So when we check their blood sugar or prepare them for a meal, we take all of this information in and we make the best decision as far as what they should eat, and how much insulin they should be getting. Now, last but certainly not least, we're going to talk about wound care, preventing of infection. So you'll see here is a diabetic foot ulcer, a big one here, and this is how it can sometimes tunnel and get deep if it's not cared for correctly. And it can also develop small ones here. Okay, so to prevent an infection in patients with diabetes, we want to avoid letting them walk barefoot at all. They should never be walking barefoot. Why? Because if you're walking barefoot, you're leaving your feet susceptible to stepping on something that can cause a cut. And patients with diabetes, we talked about how they have microvascular breakdown. So if there's a cut, their foot may not be as sensitive to the cut. It may not hurt as much as it should and direct their attention to it. So it may go unnoted, which may go missed by the nursing staff, left untreated, and here we are with a diabetic foot ulcer. So always, patients shouldn't be wearing socks or shoes. Now, if they do sustain a diabetic foot ulcer or you see one forming, we should start cleaning it and using a dressing or bandage and really nursing it. Because, we have to we walk on our feet. That's where all of our pressure goes. So we want to make sure that if the patient we do see some pressure to the area, that we start to offload the pressure to the foot. And offloading technique would be, if it's on the foot, while the patient is sitting down in the chair or laying down in the bed. We prop their foot off of the bed completely, tucking several pillows underneath the calf, which will raise their foot off of the bed so nothing's touching it. And that is called offloading. Also, any medication, anytime we're doing a dressing change in the room, giving a bath, we want to get the medication, if there is one prescribed, from the nurse and apply it if we're allowed to. If not, ask them if they would like to come apply it. Let them know we're cleaning, we're changing the dressing needs to be changed, so forth and so on. And last, in wound care management, what we can do is closely monitor their diet. By monitoring their diet, we can control their blood sugar. And by controlling their blood sugar, we can free up some space in that microvasculature for more blood to flow to those extremities and hopefully bring oxygen and nutrients with them to help heal those diabetic foot ulcers. So I have a quick video for you guys. Let's get this up. And this is a quick video on diabetic foot ulcer management.
If you're diabetic, taking care of your feet is important to prevent problems from developing. Here are some steps that you can take for good home foot care. Wash your feet daily with mild soap and water. Dry your feet well, especially between your toes. Keep your feet protected by wearing warm socks in the winter and breathable socks in the summer. Always wear shoes or slippers at home to protect your feet from injury. Avoid narrow or pointed toe shoes. Never walk barefoot or apply direct heat to your feet or legs, such as hot soaks or electric heating pads. Inspect your feet daily for sores or changes to your skin. And remember, always call your doctor and your podiatrist for preventative care and therapies.
All right. So she gave us a lot of information really quick, a lot of great information at that. So some key points I want to touch on that she brought up, daily foot bath, and we saw how she was thoroughly drying in between the toes. So we want to adapt that into our care for the patient.
This is Dinesh. I'm going to introduce you to my recent review article on nanotechnology and diabetic wound healing. As we all know that the incidence rates of diabetes is on a rise.
Oh, sorry, sir. We're in the middle of a presentation. Okay, so we're drying in between the toes. We always want to make sure that the patient is wearing shoes or slippers or socks, never walking barefoot, and we never never apply direct heat to the feet or the legs. Now, why wouldn't we apply direct heat to the feet or the legs? Because again, patients with diabetes, they have decreased blood flow because of the microvascular breakdown, and decreased blood flow. It may mean that some of you may had an arm that falls asleep. So just how that arm is numb, their leg is numb, you apply direct heat to it. They can't tell you if it's too hot because to them, it doesn't feel too hot. It feels nice and warm, but it's actually burning the skin and the tissue. So we never apply direct heat to a diabetic's lower feet, leg, or area. That is the end of the presentation. So we're going to I have 2 review questions for you guys. Let's jump into it and see how you fare. So the first question is, while providing care to one of your diabetic patients, you notice they are sweating and very irritable. The patient then asks you if you can bring them some water and tells you their vision is a little blurry, which is abnormal for this patient. It is very likely that this patient is suffering from which of the following? Are they suffering from hyperglycemia, hypertension, DKA, or hypoglycemia. So there are specific symptoms that I talked about in the presentation that this patient is also experiencing, which should clue you in that this patient is likely suffering from what disease. Give you a minute to figure that out. All right. Hypoglycemia is the correct answer. If you selected this, then that means you are paying attention. You recalled the tired mnemonic and you noted those same symptoms that we talked about, which uh, a patient might exhibit if they are experiencing hypoglycemia in this scenario here, and correctly identified the answer. So you may have just saw that answer, but the nurse tells you, this is question number 2, the nurse tells you the patient is having a serious hypoglycemic episode and asks you to bring 15 grams of a carbohydrate to raise their sugar. Which of the following items would you bring to the nurse from the refrigerator? Would you bring 8 ounces of orange juice, 4 ounces of milk, 4 ounces of orange juice, or 4 ounces of their favorite diet soda? So the patient's in a hypoglycemic episode. The nurse turns to you and asks you to bring 15 grams of a carbohydrate to raise the sugar. Which item, if you saw all 4 in the refrigerator, would you grab and bring to the nurse? This should be very simple for you guys. I made sure I reiterated this. Correct answer is C, 4 ounces of orange juice, not 8 ounces. If you remembered 8 ounces or you selected A, you were thinking of 8 ounces of milk. 8 ounces of milk, 4 ounces of orange juice, or 4 ounces of their favorite soda, but not the diet version. We bring them the regular version. So we met all of our course objectives for today. Hopefully you understand the different types of diabetes and how the disease affects the body. We talked about diabetes type 1, diabetes type 2, and gestational diabetes. And we also talked about how diabetes and hypertension can lead to stroke, heart failure, and microvascular breakdown, which can lead to retinopathy, problems with the patient's eye. So we talked about all those different ways that diabetes slowly breaks down the body and can cause other serious effect to the body. Our second objective was identifying signs and symptoms of hypoglycemia and hyperglycemia and aspects of the emergency treatment plans. So we talked about hypoglycemia, the mnemonic tired, and we talked about hyperglycemia and how I refer to that as the too much food effect. And we talked about emergency treatment plan for hypoglycemia, which was the 15 to 20 grams of a carbohydrate if the blood sugar is less than 70, and then we wait 15 minutes to check it again. And if it's less than 70 still, we give another 15 to 20 grams. And if it's over, then we feed the patient unless their normal meal time is more than an hour away. Then we give them 7 grams of protein and we wait to feed them a full meal. Third objective, identify elements of a proper nutrition plan for the patient with diabetes. We talked about this. We talked about the different types of foods, making smarter choices. We talked about the levels of eating healthy, of eating unhealthy, eating healthy, and then healthy eating for the diabetic. I showed you guys better selections for fruits, for snacks, to help them with their choices. And we talked about the 9-inch plate, how we divide it into a half, and then we divide 1/2 into 2 halves, and we leave 1/2 as one whole half. So there are 3 parts The larger part, of course, with green leafy vegetables. The other two parts should be starch and protein. And we should not stray from the 9-inch plate. And last, our course objective was understanding the importance of and being able to verbalize methods to prevent and treat diabetic foot ulcers. We just watched the video. Make sure your patient is never walking barefoot, always wearing socks or shoes, and we're checking their feet every day. This is really the biggest way to prevent diabetic foot ulcers, is to check the patient's feet every day for any new for any scratches, anything that might turn into a foot ulcer. So this is the end of the presentation. You made it. I want to thank you for being with me for the past hour. Again, my name is Deontay J. Marquis. I'm a family nurse practitioner in Southern California, presenting to you on behalf of my ALF Training. And I do hope you guys learned a lot and have a good day. Thank you.